Hello everyone, I'm Rachel Moss and I'm a transfusion practitioner at Great Ormond Street Hospital in London, and I'm also the Deputy Chair of the ISBT Transfusion Practitioner Group. Welcome to our ISBT podcast, Transfusion Practitioners Around the World. Transfusion practitioners have expertise in many different clinical specialties. So for this episode and our next 5 episodes, we are talking to transfusion practitioners working in some of these specialist areas. Today's episode is transfusion practitioners working in haematology and oncology. If you are not sure what transfusion practitioners are, you may want to go back and listen to our first podcast, What is a Transfusion Practitioner? Transfusion to haematology and oncology patients accounts for a large proportion of the transfusion activity in many healthcare settings. In Australia, 34% of red cells are used in cancer and blood diseases. Within the UK, observational studies have indicated that 50% for medical patients and haematology and oncology account for a huge proportion of that. We know that haematology patients are considered as malignant or non-malignant. So for today's podcast, we are focusing on malignant haematology and oncology patients, both adults and children. We are really fortunate to be able to bring you this podcast thanks to the support from the International Society of Blood Transfusion, known as ISBT. ISBT is a global community of professionals sharing knowledge to enhance transfusion practice and blood management. The Society does this by providing opportunities for advancing knowledge and education and by advocacy for the welfare of blood donors and patients. ISBT has many working groups that focus on specific topics or areas of expertise, and one of those is the Transfusion Practitioners Group. So now we are going to meet our guests and my co-host for today. We're having 2 conversations. We're going to talk to a transfusion practitioner from the UK and one from Australia. So I'm going to introduce my UK colleague, Wendy. Please introduce yourself.
So I'm Wendy Mixbourne. I am a transfusion practitioner of about 20 years now. A ridiculously long time. I've been registered as a nurse for 32 years. I'm an adult nurse and I trained in Scotland in Dundee and have worked in quite a few specialties before eventually landing in haematology. So I was a haematology nurse for quite a few years, about 10 years, and I've worked Cambridge Transplant Unit and Hammersmith Hospital Transplant Unit before finally deciding to become a transfusion practitioner. And I've worked as a transfusion practitioner at Imperial College London and now at the Royal Marsden in London.
Thanks, Wendy. And now I'm going to hand over to my co-host, Lindley, who will introduce herself and then her guest for today.
Well, hi, everybody. I'm Lindley Bilby and I manage a program called Blood Matters in Victoria, Australia. The program aims to support and enhance best practice in patient blood management and the stewardship of blood and blood products. And I've also have the privilege of being the chair of the International Society of Blood Transfusion Practitioner subgroup. And today I'm going to be talking with Michelle Edwards. So Michelle, would you like to introduce yourself?
Yeah, sure. Thanks for having me, everyone. I am Michelle. I'm a bit of a newer transfusion practitioner. I've been working at Peter MacCallum Cancer Centre here in Melbourne for the last year and a half. Prior to that, and I've been working as a paediatric oncology nurse for just over 11 years. And actually prior to that, I was a veterinary nurse. So I've switched over from animals to people, and the first ever transfusion I was involved in was actually a dog-to-dog transfusion, so a little bit less regulated than some of the adult ones that we use these days, but certainly something quite interesting to have been a part of nonetheless.
Oh, brilliant. Thanks, everyone. So we're just going to ask Wendy and Michelle a number of questions. They're going to tell us some answers, tell us their thoughts and feelings. And hopefully this will really give you a good idea of how transfusion practitioners work in this specialty. So I'm going to start with Wendy. Thanks for being with us today and giving up your time. We really appreciate it. So thinking about haematology setting and haematology oncology setting, tell us your background. You've mentioned your background about how you came to this, but what is it about this specialty, do you think, that got you here?
Probably 2 things in particular. So, one was obviously clinically the amount of transfusions that I had administered, but in particular, there was one patient that I looked after, and I think I've told you about this, Rach, but it's not something I talk about a lot because I don't know why actually, because I think it's still fairly horrible experience. But I'd looked after a patient for a long time, and she'd had an allograft. I think she'd had an allograft transplant, and she was well. She had recovered. She had gone home. She was about 6 months out of transplant. And she came back into the daycare unit, and it must have been on the day that I was carrying the bleep for the unit, because the crash call went off fairly early in the morning. And I remember running up to the outpatient department, and she'd just finished having a pack of platelets, and she had become acutely breathless. And so I remember running off to get a suction machine and various bits and pieces, but she was okay. She recovered from that episode, but she didn't recover full stop. She came down to the ward and stabilised, and then was later moved to ITU and died in ITU 7 days later. So that was the first time, I think, in my life that I had ever looked after, and hopefully it hasn't happened to many people, someone who was completely well, had a blood component, and then died from having a blood component. And then so I became really interested in, obviously, and I don't even know then that we didn't have transfusion practitioners. This would probably be about 98, 99. And I don't even know if then we knew it was Trally, if that had been named, but looking back now, it quite obviously was. But I just became really interested in appropriate transfusion at that point. And I already really enjoyed teaching. So it must have been shortly after the Better Blood Transfusion white papers came out, the Trust decided to advertise for the first time for a transfusion practitioner. And I was just hugely interested, mostly because it involved a subject that I was already interested in because of that episode, but also because it involved a lot of teaching. And that was something I really wanted to do. And I always just wanted to work, in a specialty where you could really get stuck in, know absolutely everything about it, become quite passionate about it, and just tailor down to doing one thing every day. And I have to say, it's not something I ever regret doing.
Oh, yeah. Fantastic. Oh, I love this job. Michelle, tell us how you know all about your specialty and getting here and thoughts and things.
Yeah, I'm not sure that I had quite as a significant or dramatic one instance as that, but I certainly have been given a lot of blood in my time, having been being a baby grad nurse in paediatric oncology, so at the Children's Hospital. So I've given a lot of blood over all of those years, but I particularly have always had a real interest in the haematology type cancers. That's been just something I've always been drawn to. I'm not sure if it's just the science behind it, the way the treatment kind of works. It's just something that's always been really fascinating to me, and particularly the bone marrow transplant suite is an area that have a real passion for and really enjoy working in particularly. And then, many years ago, I remember an in-service being provided by our transfusion practitioner at the Children's, and for whatever reason, it just kind of really stuck with me, whether it was the topic or just being like, oh my gosh, this person just knows so much. And that's really amazing to me. And that just always really stuck with me. And so when an opportunity came to join the blood management committee as a clinical nurse, I took that up. So I've been a member of that committee for quite a while, and it gave a real insight into a different aspect of the hospital and also transfusion and how all of that works, and got to start making some, new networking. And then as a clinical nurse specialist, I have now taken over the blood portfolio or blood management portfolio. And that's been a really great opportunity to really, as Wendy mentioned, education is something I'm really passionate about and something I really am drawn to as well. And it's a role that really allows you to learn a lot, which I enjoy myself, as well as then be teaching. And I do have some of the people on the ward that refer to me as the Blood Queen, which is quite an interesting title, but I do get that quite a lot. And so really when this opportunity came up for a part-time role, so it was a role where I was going to be able to be working alongside a transfusion practitioner who had been working in the role for a very long time, it just it seemed like a very natural progression, that it really drew together a lot of my interests and seemed like a really fantastic opportunity to kind of get a foot in the door and get stuck in. And since then, and it happened to be in oncology, which is something that I already knew a lot about, even though it still freaks me out that in adults we give whole units of blood to everyone. As a pediatric nurse, that's quite scary. Our little people often get a lot less. But yeah, it's been great since then, and to get a lot of opportunities ongoing from that, even in a year and a half. I've had the opportunity now to join the Australia-New Zealand Society of Blood Transfusion, the new Transfusion Practitioner Working Group, which is a really great opportunity as well. So certainly, again, not something I regret. And even though I'm still quite new, I feel like I've learnt just an incredible amount in a year and a half. Look forward to learning some more.
Fantastic. Thanks, Michelle. I love that we always have so many similarities despite our time differences and distances away. So, Wen, just going to start with you. Do you think hem-onc is different from other specialties when we're transfusing patients?
So when I seen, obviously we get sent the questions in advance, and so when I seen this question, I thought, am I even qualified to answer this now? Because I've worked in the specialty for 10 years. So can I in the recesses of my brain actually remember how it feels to cover a trust that isn't just cancer care? And just about. So I think it's a bit of yes and no, isn't it? It has to be. So it's the same as every place else because the guidelines are the same. The risks and benefits are often the same. How you apply them, I think, might be slightly different. So the body of work and the research that's around, restrictive transfusion, 1 unit transfusions, it applies equally, I think, to all specialties. So that part is the same. So I guess that leads to, so what is different? I think obviously you've got to mention the fact that quite a few, especially haematology patients, have special requirements in the way of irradiated. The new kid on the block is obviously the MABs, or maybe they're not that new any longer. But having drugs being given that interfere with the cross match, obviously in terms of, I feel for clinical staff at the moment because there is so many priorities going on. But then when you add into that how much forward planning they now have to do in order to transfuse patients, it's fairly high. We're having to rely more and more on our National Blood Service, so NHS Blood and Transplant, providing blood for us. And so there's quite a lot of coordination goes on in terms of sample timing, when that blood will be available, and then actually getting a chair space or a bed space. So yeah, I think that's different. And then thinking about it, the most conversations that I have had is when applying restrictive transfusions and even consent in relation to this, but I won't talk too much about that at the moment. It's often about end-of-life care and how transfusion is applied then, and sort of sensitive conversations around when does quality of life and the benefits from having a higher haemoglobin to allow you to have a good quality of life outweigh the benefits of a restrictive transfusion. And I've also been quite mindful of the fact that for a lot of cancer patients, the last thing they ever want to do is spend time in hospital. All our time is precious, but I think at that point in your life, you become acutely aware of just how precious time is. So I was initially concerned when there was a move towards 1 unit transfusions, because I wanted to be assured that by doing a 1 unit transfusion, I wasn't going to ask a patient to come back more frequently. Again, because I'm aware that they just don't want to set foot inside the building, if at all possible, for fairly obvious reasons. So fortunately, the research was actually you're not having to come back more often just because you're having a 1 unit transfusion. So that is now the same. So yeah, bit of yes and no. I'm sure if I had more active brain cells this morning, I could probably come up with a few reasons for difference, but I think I'll leave it there and I'll come back.
No, I think that's great, and I think they're really good points. Michelle, anything you want to add to that?
Yeah, I think there's a few things, and again, I've only worked in oncology, but I have been exposed, I guess, to quite a few other specialties working in a hospital that does a lot of other transfusion. But certainly antibodies is a huge difference, and this has been really highlighted in some education I've done recently. Our hospital opened up a sort of a step down from ICU type of unit, and so a lot of the staff have come in from ICU or other critical care areas and not necessarily having a lot of knowledge about oncology patients, and they've been quite surprised at actually seeing patients with antibodies, which we see quite frequently because so many of our oncology patients are receiving not just a one-off transfusion, but receiving multiple transfusions over a long period of time. So they have such a higher risk of that. Certainly it's something that the blood bank is always having to deal with and negotiate quite a lot. So that's certainly something that was really highlighted to me recently, how much of a difference that has, and therefore what blood is available to those patients. And if they're having perhaps a major surgery or perhaps a major, critical bleeding incident, what are the impacts of being able to find blood that's going to be appropriate for those patients who might be at much more high risk of some sort of a transfusion reaction. Certainly the special requirements Wendy touched on, and the irradiation, our hospital is quite interesting in that all of our stock is irradiated because our whole hospital is oncology patients, and so our whole inventory is irradiated, whereas at the other hospital I work, it's irradiated just for certain points. And then just the long-term patients. So we've got immunoglobulins that patients are receiving for years upon years upon years. Just that the type of patient is quite different. And then the coagulopathies that you get as well with a lot of cancer patients, and how to manage that, different types of products that we would use that perhaps wouldn't be seen elsewhere. I think that's probably, enough points there.
Yeah, I think that's why they use so much transfusion and why we need. So which leads us on to our next question, that one of the things Lindley and I know is that not all areas have transfusion practitioners. It's a relatively new role in a lot of countries, and one of the things we're doing at ISBT is promoting the role. So Wendy, what do you think is the positive impact that having a transfusion practitioner in this specialty makes?
I think that transfusion practitioners should have the knowledge and broad bandwidth to give more individualised care than clinical staff have got time for very often at the moment. So it's the fact that you can, every single conversation tends to be education these days. I think there's very few conversations where I don't manage to shoehorn in something extra that somebody wasn't expecting about transfusion, just because the sheer opportunity presents itself. So I think it's being able to join all the dots. So, for example, I think transfusion doesn't get the buy-in sometimes, especially from medical staff, that it deserves, because it doesn't look like it's always intellectually challenging. But actually, when you do it properly, there is quite a few dots that you need to join up in order to look after somebody's transfusion management really well. So, for example, especially in cancer care, actually, this might be one of the differences. The symptoms that people present with are often symptoms of cancer, but could easily be anemia. So it's unpicking, does that person really need to be transfused? And it's not as easy as at first sight. And you have got the time, energy and will usually in order to intervene and offer expert clinical advice. And also you have patients presenting all the time, whereas, sorry, I have just realised that the person outside is hoovering. Shall I stop and start? You can't hear it. Okay. I was just going to say, the other issue that we have is patients who first present, whether it's haematology or oncology, you're not sure initially very often whether they're suffering from a functional iron deficiency, so checking their hematinics and checking what's going on, or a non-functional. So obviously on some occasions we correct their iron, but then they don't respond to that as you expect because they also have a mixture of deficiencies. So I think what the TPs offer, just the ability to think all that through, to do the analysis, and then to offer really individualised advice, as well as educating the department and having a passion for the subject to get it right and to make sure appropriate transfusion takes place, as well as you well know, doing the audits to make sure that everybody is playing ball nicely. And I think just having a global perspective of the subject and keeping everybody interested, hopefully, and doing the very best for the patient.
Fantastic answer. Michelle, over to you. What do you think a TP brings to your specialty?
Not quite sure how to follow that answer. No, I think certainly that liaison role, which I know that is a big part of the TP role, regardless of what area you're working at, but to be a liaison between the clinical staff, the blood bank and haematology, and I think it's even more critical in the haematology oncology role, just because of all of those other things we've already spoken about that can be different about the oncology patients themselves. Certainly we do a lot of transfusion reaction investigations, which can be very tricky to tease out because just like anemia symptoms can be mimicked, there can be a lot of other things like febrile neutropenia that look very similar to a febrile reaction. So being able to deep dive into that and then feedback to the clinical team what might be the most appropriate management moving forward. I think that's a really important role as well. And certainly the education, as Wendy touched on, you know, nursing staff particularly have so many different aspects to their role and aren't just thinking about one thing at any given time, whereas that is something that we are doing. And so being able to get in and to highlight what are the important steps, what are the most, the safest way to do this transfusion, how can I support you, how can I come to the ward and give a hand if need be another resource, I think is really important. And particularly with the new graduates has been a really good opportunity to get in and teach about what are the things we need to think about differently with oncology to what you've been trained perhaps as you've been going through nursing school, and where can we look at things a little bit differently.
Well, student nurses and blood transfusion is a whole other topic. Maybe we'll do that in a future date, Lindley. Right, Michelle, I'm going to come back to you again. This patient group requires some really intensive treatments and therapies, and we know that transfusion support is just a part of that. Wendy's already touched on some of the drugs. But in your experience, what's the patient's understanding of why they need transfusions? And I suppose for this mainly will be our adult patients, but, you can touch on children because that's also your expertise. And what about consent? And in the interest of time, I know we could talk about consent, so brevity is our friend, but in consent and the overall consent for treatment, is it done part of it separately? What happens at Peter Mac?
Yeah, so consent is certainly done separately to their overall treatment, because the overall treatment of a lot of these conditions is more related to chemotherapy. It's often very driven by clinical trials. A lot of oncology treatment is driven very heavily by clinical trials, and that requires different consent to what a blood transfusion would, and the risks and benefits are perhaps different, even though they're intertwined and as to why they might need that transfusion, but it's certainly done separately. And then we have a couple of different forms of consent depending on what the patient's cancer diagnosis is. So if it's perhaps a more surgical or solid tumour type case where they might just be coming in for a surgery and maybe requiring transfusion then, but maybe not ongoing, they may just get a consent for one admission, whereas a lot of our longer term patients will get an enduring consent. So they'll essentially consent one time that covers their whole treatment episode, which may be over a year or a couple of years. And I think also their understanding of consent depends a little bit on the product that they're consenting for. So we do find that some patients may have consented for fresh blood products and they may now be requiring immunoglobulins, and that's a little bit of a different consent. So certainly we've actually done a recent audit, as in last week, that was very pleasing to see that the feedback from patients was actually that the consent discussions that were being had were very much answering all of their questions prior to transfusion. So that's been really pleasing to see.
Haven't got envy at all about your lovely audits, but let's gloss over that. Wen, anything you want to add about the patient's understanding and consent?
So no, our consent seems really similar to Michelle's, as in patients are being consented before transplant as part of their workup for transplant. And then as part of their overall treatment regime when it's oncology. Again, because of end-of-life conversations, I remember this really clearly when we first ratified a written consent form for the Trust. Quite a lot of discussion about the sensitivity about having to keep going back to patients and reconsenting in palliative care. So we have a consent form where you can do a predefined period, and then the patient is obviously told that they can withdraw consent at any time. But they won't be asked about consent again until whatever the specified period is on the consent form. And I would say when I have gone and audited, which it's not often because it always seems to be quite a extensive amount of time for performing the audit, when I've gone and asked patients what they felt about the consent process and did they get the information that they required and what can they remember about it, the first question before I've even managed to ask that is always, is my cancer worse in the adult population? I'm not sure that I've ever addressed that adequately as a transfusion practitioner across an organisation, but I am very much aware that patients are almost using it as a surrogate marker of their current disease status, especially if they have not been transfused for a couple of months and then for whatever reason they need to be transfused that day. So I always think reassurance probably comes first and foremost around transfusions within the cancer setting.
Gosh, very interesting. Hadn't really thought of that. You touched on audit, so let's stick with audit for you, Michelle. We would assume that having to transfuse regularly, staff would be proficient and safe in their transfusion practice, but of course we are human beings. Do you audit other areas of transfusion practice within your specialties?
Yes, we do do a few audits. We also have quite an extensive blood competency process at our hospital, perhaps acknowledging that there are some different requirements with this particular group of patients. So part of that competency is very much a practical session as well. But we do a couple of times a year, we do a audit that's a documentation audit covering consent appropriateness of transfusion as well as documentation. And that documentation really is looking at the what the nurses are documenting within our electronic medical record. Sorry, that was a bit of a mouthful, but that's where we do all of our transfusion documentation. And sometimes, you're looking at a screen, and so sometimes it is really helpful to talk to people as well to get an understanding of what has been happening. But you can see trends of, are people looking at, are they doing observations at the correct time points? And if there is something that is not happening the way it's meant to be happening, are they following that up? And then we can follow up on those results to feedback to the clinical areas. Perhaps there's been some gaps. So one we saw recently was an area where there were perhaps a lot of newer staff that had been coming on, and they were diligently doing their units regular obs, but missing the transfusion, within a transfusion, the temperature at the more frequent time checks. So they were doing their, I've got to do my obs at these time points, but forgetting that actually temperature is one of the perhaps more important observations when you're looking at transfusion, particularly in oncology patients. So that was a little bit of a gap of knowledge we were able to identify and then go and address specifically with those staff. And I think that can be a really helpful auditing tool from that point of view. We do occasionally do some observational audits. And then, yes, this consent audit we've done more recently as well. And then I guess it depends on what else comes up. So if there's been a bit of an issue that we need to address and go back and look at things a little bit more in detail. Perhaps we've had a new immunoglobulin product come out in Australia over the last year, and anyone that works in Australia would know all about this and the impact it's had on different reactions. And then, so we've had to go a little bit more deep diving into what patients are experiencing to be able to make sure that we're giving them the most appropriate management.
Brilliant. Yes. I love the fact that everything is the same, or different. Wendy, audits within your specialty, what sort of things have you been picking up on?
Okay, now I want to know what the product is. Anyway, audits. I think that we have audited audits. And so we participate in the national comparative audits, obviously run in the UK. I think by the time we get through the national comparative audits and then actually working on the results and any action that needs done, yeah, we've managed to do local audits in between that, but I have to say not many. At the moment, we're also participated in the fairly newly launched about 6 months ago, I think, the Quality Standards 138 tool, whereby you can audit and then report more in real time to see if that had an influence. And the one thing that I also got to participate, now this is not local audits, and this is probably not what you wanted to ask me about, but I'm dovetailing it in anyway. So I worked with the sort of national audit committee on the Affinity trial, looking at how we can make audits more effective. Because one of the things that I'm quite passionate about is the amount of time that TPs actually spend all the time, probably for very little benefit. I know we have to measure things, but I think we also need to spend equal amount of time looking at how we make those results meaningful to clinical staff and implemented. So yeah, we audit, but I'm not sure how successful we have then been at changing practice.
Yeah, I don't think many people would argue that. Right, we're heading towards our final question now. So, Michelle, patient blood management, it's very important to us at ISBT and in all healthcare settings where patients are transfused. Do you think there are any specific patient blood management approaches that within the haematology oncology setting particularly that are beneficial?
Yeah, I think certainly I think you have to really look at numbers versus clinical symptoms when you're looking at transfusion. So we might have particular criteria of a hemoglobin of 70 will transfuse below, but pediatrics, you might have a 2-year-old who's got a hemoglobin of 60 and they're running around like everything is fine, and you might have a teenager who's got a hemoglobin of 85 who's feeling particularly fatigued and really noticing those symptoms. So I think certainly having some flexibility perhaps within the management and bit of common sense. I know that's perhaps not a strategy, but I do think sometimes it is quite important to look at the whole picture of what's happening for a patient before determining what type of blood they might need. Certainly we do look at single unit transfusion in most cases, and that has been a difference that I've seen over my practice over the last 10, 11 years, that certainly we've reduced the number of upfront double transfusions significantly that we used to do. And I think that there's a few other things, like a lot of our patients have central lines. So are we thinking about clustering any blood sampling that we need to be taking, because we're needing to take a discard of blood for a lot of these patients. So that's some loss that we're taking. So are we being quite careful with how we're collecting blood samples, knowing that these patients are getting a lot of blood sampling, perhaps daily, perhaps often more than once a day. So how are we thinking about how we can do that well? We do also think a lot about where the patient is in their treatment cycle. So if they've had some chemotherapy and they've reached their nadir point, so where all of their cells have kind of dropped off and before they're starting to regrow and start to recover, whereabouts are they on that journey? Because maybe the hemoglobin's a little bit low, but perhaps they're looking like they're going to start producing their own cells. So maybe we can hold off for another day and see what their body's going to do, and is it going to have an effect without us having to do a transfusion. So I think very much looking at whereabouts they are on the journey. And then also the acute versus chronic patients we might manage a little bit differently, and it has to be a little bit individually tailored perhaps. So these patients that require chronic transfusion support, what's going to work best for them to get them a good quality of life result? And that's not a one-size-fits-all approach. So I think that's something that we really have to consider with patient blood management for those patients.
Yeah. Strangely enough, putting the word patient in the middle of what we're doing there, looking at our patients. Wendy, what about you and PBM strategies?
I agree with everything Michelle said. Brilliant answer. I had actually managed to forget about the trend up the way when you're actually engrafted. I'm going to put that back in my teaching. Thank you. But I would say recently, one of the biggest differences we've had in terms of how much PBM has been utilised at the trust. The point I'm always looking for is who do I have to influence a whole service change? And so we started doing non-medical authorisation of red cells and platelets probably about 8 years ago now. And that had a huge impact, because I had read a PhD done by Liz Bishop that essentially said that very often, if you don't have lots of education going on in a clinical area, transfusion is often based on socialisation and practice. So whatever your senior nursing team are dictating is the right thing to do is what they teach junior doctors, who actually have the pen and will essentially prescribe whatever they're being asked to prescribe by senior nursing staff. So one of the most effective measures we then had was, okay, so we will train the senior nursing staff to be the non-medical authorisers, and then the prescriptions will be more appropriate. And so I audited that, and I have subsequently written and done a poster about that, and that was very much the case. We tended to transfuse within guidelines and 1 unit transfusions, and basically a lot more guideline compliant than it had been, and a huge influence on medical practice as well. So yeah, and we also have a team now which is just looking after iron infusions and managing functional and non-functional anemia, which has been really successful as well.
That's really great, Michelle and Wendy. I've learnt so much, and it's been really great having you both spend and share your time with us. So thank you very much for that. And it was really great to hear you talking about non-medical authorisation, Wendy, because we've actually had a couple of podcasts around that topic. So our listeners might like to go back and have a look at that if they're not really sure about that kind of area. We've discussed that transfusion is actually a really big part of looking after these patients in the haematology oncology setting, and that the transfusion practitioner, from what you've told us and from what we know from our experience, really have a positive impact on the patients that are undergoing treatment and the clinical team who are managing those patients. So thank you. We'd also like to thank all the listeners for joining us today, and if you've got any feedback, to please use the questions that we have linked in our podcast. If you've got further questions, you can link with us through the ISBT website and the Clinical Transfusion Working Party, where you'll find more details about the Transfusion Practitioner subgroup. So we look forward to having you join us again for our next episode, where we're going to be highlighting the transfusions practitioners who are working with patients and clinical staff in the obstetric setting, where we're going to be looking a bit about postpartum hemorrhage, RHD, and also anemia management. So until then, thanks very much for listening.